Okay, hello everyone. How are you? I'm Shaimaa Mohammed, and with me is Momo Arai, and we're fourth year medical students, and today we're going to have the pathology practice questions, inshallah, for endo rep. So we can start immediately. Okay. It's a very long question. So would anyone be willing to read it, or should I just start?
Wait, this is yours, right? I just want to make sure. Because mine are also as long.
Yeah, no, mine is so long. Okay, plus I'll read it. A previously healthy 42-year-old male presents to the primary care physician with progressively worsening headaches and loss of peripheral vision over the past 4 months. The patient reports that driving has become difficult due to his vision problems. He denies weight changes, palpitations, diaphoresis, heat intolerance, appetite changes, arthralgias, whatever. He's monogamous with his wife, and they have been attempting to conceive for the past 9 months. Frequent intercourse has been difficult due to his reduced sex drive and new erectile dysfunction. He denies a history of depression. Vital signs include a temperature of 36. Everything is around the same normal. Physical exam reveals a healthy appearing middle-aged man. He is in normal sinus rhythm and lung fields are clear bilaterally. The abdomen is soft, non-tender, non-distended. Visual testing reveals bilateral temporal vision loss. A contrast-enhanced MRI with SELA protocol is ordered, demonstrating the suprasellar extension of a pituitary mass compressing the anterior aspect of the optic chiasm. This mass most likely contains what under histopathology? If we look at the symptoms, what are they mainly symptoms of? Okay, someone's saying prolactinoma. So yes, first of all, we know it's pituitary, the bilateral temporal loss because of the optic chiasma, but also with pituitary, we have the, because it suppresses GnRH, therefore there's decreased libido. That is for males. In females, you can see the galactorrhea. However, it's more difficult in males. So you're correct, it's prolactinoma. So which one is prolactinoma? That's the question. Okay, you're saying E. There are two E's, one B, and one F. Two F's now. Okay. Play it. And another E. So the answer is F. So where in prolactinoma, amyloid deposits and microcalcifications are usually present. Where do you usually see acidophilic cells? For those who said F or E. Yes, growth hormone will have acidophilic cells. Where do you usually see? So for lactotrophs, most of the time, because prolactinoma, it's chromophobic. The tumor is usually chromophobic. Sometimes it can be acidophilic, but most likely it's not going to be. It's going to be chromophobic. What about PAS positive? ACTH. Yes, inshallah, Faisal. Okay, so as you can see, usually pituitary adenomas, you have uniform polygonal cells with sparse reticulin. In prolactinoma, which is the most common type of adenoma, you're going to find chromophobe cells that are sparsely granulated. And you're going to find amyloid depositions and microcalcifications. Yes, sometimes you can find acidophilic dense, but usually it's not. For growth hormones, they're usually macroadenomas, and there are two types, either densely, which is acidophilic, and they react with growth hormone, or sparse, which are chromophobic, so similar to prolactinoma, and they don't really have reactivity to growth hormone on immunohistochemistry. And then there's the mixed type between the somatotrophs and lactotrophs. So this one is usually densely granulated and acidophilic, but it's like this one. However, it's going to have both growth hormone and prolactin activity on immunohistochemistry. Lastly is the ACTH adenoma. So you're going to see it's usually micro. So growth hormone, big macro, ACTH is usually micro, and you're going to find Pas positive. And again, it's densely granulated, but basophilic. So GH is acidophilic, ACTH is basophilic, and prolactinoma is chromophobic. So what is the finding in this one? Usually they won't get you like a picture of pituitary for you to differentiate between the pituitary adenomas because it's very difficult. But this is like a typical pituitary adenoma. What are the findings that we said are main in it? 2 findings. Uniform, yes, uniform polygonal cells. What about the connective tissue? Yes, parasitically. Perfect. Okay. So that's it. Okay. So the next question. A 21-year-old woman delivers a term infant after an uncomplicated pregnancy. The placenta cannot be delivered, however, and there is substantial hemorrhage, requiring transfusion of 10 packs of RBCs. She must undergo a hysterectomy. Over the next 3 months, she is unable to produce sufficient breast milk to breastfeed her infant. She becomes increasingly fatigued. Lab studies show sodium is low, potassium is a little high, chloride, I'm not very sure. Basically, over the next 5 months, her menstrual cycles do not return. Which of the following lab findings is now most likely to be reported? So I see 2 Fs. Lack of corticotropin-releasing hormone. Okay. Anyone has a different answer? Okay. So I'm saying lack of ACTH and ADH, but that's not one of the options. Which one of the options is correct? Everyone agrees to F? Someone is saying B. Okay, guys, she's a pregnant woman. What happens in Sheehan syndrome? Basically, because during pregnancy, there's a lot of prolactin and the pituitary gland grows to almost double its size. However, the blood vessels, they don't increase. So there's going to be decreased perfusion to the gland. And if you have hemorrhage, basically there's going to be infarction or ischemia to the pituitary gland. So someone's saying A. Okay, let's get dopamine and ADH out of the way because, oxytocin and ADH out of the way because the posterior pituitary is not affected, only the anterior pituitary because the posterior has its own blood supply. So these are posterior thingies, so A and D barra. So you have the rest. Where does CRH come from? From the pituitary or from the hypothalamus? From the hypothalamus. So we can remove this because the damage is to the pituitary. Okay, now you're left with increased corticotropin, which is ACTH, and elevated dopamine and growth hormone stimulation. Okay. Why elevated dopamine? Okay, if there's no PR, which one is more likely though? Yes, it's C. Basically, there's decreased growth hormone. There's not going to be increased ACTH and dopamine. It's not only for prolactin, yani. There's a lot of things that use dopamine. And it's not directly in the pituitary gland. So the best answer is decreased growth hormone due to Sheehan syndrome. I hope you guys get this question because there was some confusion. Does anyone need like an explanation to why it's C?
I feel like for dopamine, isn't like dopamine inhibits prolactin, but
Yeah, it inhibits.
right? It's not that's why it's fine. I don't think it's B. Like I would cross out B because of that.
Mhm. Why is C not relevant to the case? Basically, in Sheehan syndrome, you're going to lose most of your, because there's pituitary infarction, you're going to lose most of your hormones, ACTH, growth hormone, FSH, LH, TSH, everything. So growth hormone is one of the hormones that are affected. Yeah, so they're saying lab findings, not specifically clinical presentation. But from the clinical presentation, you can tell that prolactin is low. But for, because they're asking for labs, this is the correct answer. The others are all wrong, basically. There's not going to be effect on the hypothalamus, like the CRH is not going to be lack. Instead, because ACTH is low, there's going to be more corticotropin releasing hormone. So this is wrong. Increased corticotropin, that doesn't make sense because the glands are, the pituitary gland is destructed. Antidiuretic hormone and oxytocin, they're not affected by, the posterior pituitary is not affected by Sheehan. It's only the anterior pituitary because the posterior pituitary has its own blood supply. And yeah, so the only option left is C, basically. Got that? So like in general, hypopituitarism is when you have a destruction of more than 75% of the anterior pituitary. As we said, posterior is not affected. Sheehan, if you see the word pregnant, know that most likely it's Sheehan syndrome. Like she was pregnant and then she lost blood. No, it's Sheehan. And then you can have non-functioning adenomas that can work two ways. Either that because this adenoma is taking up space from other cells, so you have hypopituitarism, or hemorrhaging happens in this adenoma leading to apoplexy. So this is also a reason for hypopituitarism. And then we have non-neoplastic cysts like Rathke's cleft cyst and many other dermoid, arachnoid, stuff like that. But Rathke is the most common, and you have to know. And lastly, it can be neoplastic like craniopharyngioma, which has two types, or pilocytic astrocytoma. Craniopharyngioma is basically the remnant from Rathke's pouch that went up to the anterior pituitary. So yeah, those are causes of hypopituitarism. The next question, a 14-year-old boy presents with 3 months of lethargy, headaches, and muscle weakness. His parents note that he drinks water excessively. His vital signs are normal. A 24-hour urine collection shows polyuria. The fasting blood sugar is normal. An X-ray film of the brain reveals suprasellar calcification. A biopsy of similar case is shown in the image. Which of the following genetic mutations is the most likely cause? So there are two Bs. What is the diagnosis? What do you think it is? Craniopharyngioma. Okay. Does everyone agree that it's craniopharyngioma? Okay. So yes, it is craniopharyngioma. And yes, the mutation is going to be in the one signaling pathway. So what about G protein mutations? They're most commonly the cause of what? Prolactinoma, or like more generally, pituitary adenomas in general, it's G protein. What about HRAS? Yes, carcinoma. So although pituitary carcinoma is very rare, like it's only 1%, it's HRAS mutation, G protein in adenoma, and 1 in craniopharyngioma. Okay, so yeah, this is yours.
Okay, so we'll move on to the thyroid gland. So this question says a 20-year-old woman and her twin sister both experience increasing diplopia. Their conditions develop within 3 years of each other. On physical examination, they have exophthalmos and weak extraocular muscle movement. The thyroid gland is diffusely enlarged but painless in each sister, and there is no lymphadenopathy in either woman. Which of the following serum laboratory findings is most likely to be reported in these sisters? Okay, 2 people said B already. Good. So, wait, I won't say what the answer is, but if people are saying B. What's the diagnosis from the case, like from the scenario? Yeah, good. So Graves. So whenever, so that's the main point. Good job. So that's the main point I wanted to like say here. Graves is one of the most like important diseases, and whenever you see exophthalmos, that's like a key feature of Graves disease. Okay, and good, because everyone said B. I'll just say the answer. Yeah, the correct answer is B. Good job. So in Graves, as you know, there's wait, Shaimaa, can you press next because of the answer? So yeah, so because of wait, go back. Okay. Because of the increase in antibody, like the autoimmune antibodies against TSH, your body's TSH level will decrease. Okay, so just not like don't mix up those points. That's it. But if everything clear from here, can I move on? But I'm happy you guys got this right because it's a very important. Yeah. Okay, good. Okay, the next one is a 37-year-old man presents with a single firm mass within the thyroid gland. This patient's father developed a tumor of the thyroid gland when he was 32 years of age. Histological examination of the mass in this 37-year-old man reveals organoid nests of tumor cells separated by broad bands of stroma. The stroma stains positively with Congo red stain and demonstrates yellow-green birefringence. Which of the following is the most likely diagnosis? Okay, so three people said D. Do you get like, does anyone else have another answer? Okay, since everyone, mostly everyone said D, the correct answer is D. Okay, I'm really happy. So medullary carcinoma, again, the main thing is the thyroid. So yeah, good job. So Congo red. It's the only one that you need to know that stains with Congo red. Uh, do you know why it stains Congo red? Like what's the like histology? In histology, what do you see? And then you stay. Good job. Yeah, so amyloid. If you go to the next slide, there is a picture. This is from your slides, but I'm just putting them here and there so that you can get familiarized with the picture. So if you see like apple green bifringence in the Congo red stain, because this is because of the amyloid deposits in thyroid carcinoma. So that's like out of the four, this is the only one that stains with uh Congo red. Okay, is that clear? And there's more. Okay, questions on tumor. Okay, good. Okay, so this one, a tumor similar to this that's shown in the picture, is observed in a biopsy from a thyroid, and an adjacent lymph node is also involved. Which of the following descriptions of this tumor is most appropriate? Okay, so someone said C. Uh, okay, wait. I can also try to think of what the picture is first. Like, can you tell from the picture what it is? Here, someone said B. Maybe. Can you guys tell me what do you think the name of the tumor is? Or which type it is, for example? And tell me like how you can tell from the picture. Because that's another key like finding. Good. Papillary. So papillary carcinoma, how could you tell from what are like kind of the three main things that you can see? Good, yeah, Orphan Annie. There's a more clear picture in the rest, but if you zoom in this one, there's like the Orphan Annie eyes. Good. Oh, okay, it's fine. Because people said the answer, so it's okay. So Orphan Annie eyes. What else? Fibrobascular core. Yeah. And the purple. Okay, what's the purple thing that you guys see there? What's that one? Yeah, good. So Samoma bodies are found in only like a few diseases, and one of them there's actually a mnemonic in first aid, but one of them is in papillary thyroid carcinoma. It's not in the other carcinomas of the thyroid. So good job. So that one groups in nuclear inclusions, nuclear groups, and like you guys said, the fibrovascular core with the orphan Annie eyes will tell you that this is papillary carcinoma. Good job. And okay, two people said B before, so good. That's the answer. Papillary is one of the most common like thyroid tumors or cancer, but it's very slow growing and it's a good prognosis. It's the first one you guys took in your lecture. So that one is like one of the like it's one of the ones with good prognosis. The others, medullary is not so much, like it's not that good, as well as anaplastic from the name. Those are the bad prognosis ones. So good. Uh, Someone said C. Is it clear why it's like not C? Or because this one is talking about like what's the I guess like what's the most correct one? It's oh, no, yeah, it's fine then. Okay, good job. So in the next slide, I have, so like Shaimaa mentioned before, there are like a lot of genes in the repro that it's better to know them because some of them are related to like cancer, certain types of cancer. So for thyroid, at least, just know that RET, so RET gene, is like related to papillary carcinoma. And so the rest you really don't need to know like in details. I memorized this one in third year. But for example, BRAF, those are important also. So in papillary and follicular. Okay. And PTEN comes later on. For thyroid, not so much, like it's not as important. I would just focus on the RET gene and BRAF and the RAS gene. Okay. Is everything clear? Okay, good. Okay, so wait, what's the next one? Oh yeah, okay, so this is mine. So a 37-year-old woman has had difficulty swallowing and a feeling of fullness in her neck. She is recovering from a mild upper respiratory tract infection. On examination, her temperature is this. Okay, respirations are 16, blood pressure. Okay. Palpitations after diffusing enlarged thyroid elicits pain. Good job. Okay, since everyone said C, so that's what I want, like, yeah, so that's the answer, good. So subacute granulomatous thyroiditis, if you see in the question stem viral infection or upper respiratory tract infection, like she's recovering from it or she had it recently, and what other thing in this scenario is pointing towards this disease? Okay, where does it say? Does it say giant cell? Yeah, it has giant cells. Yeah. What other, so there's a specific I guess word in this question stem. Good, painful. So if a thyroid is like painful, tender, after recent viral or upper respiratory tract infection, that will point to granulomatous thyroiditis. Does anyone know the other name for it? Because it's an easier way to remember. What's the other name for this disease? Yeah, good. Decurving. So there's a mnemonic that you can try to like memorize it for, like try to remember it for later. So instead of, yeah, decurve pain. So good. So painful thyroid after viral is always this answer. Good job. Okay. Yeah, so this is from Osmosis. It's a very like Osmosis. It's so cute. So it says like viral infection. It can be adenovirus, mumps, measles, anything. If you see that, that's your answer. And painful, of course. Okay. Okay. Next question.
So, okay. I
Wait,
think
do you want
it's
me to read? Okay. Okay.
yeah. Okay. So now we're moving on from thyroid. So this is the pancreas. A 45-year-old male presents to the primary care physician for a new patient physical exam. He reports that he has been unable to see a doctor for about 15 years. He has no acute complaints and denies fevers, chills, chest pain, shortness of breath, abdominal pain, everything else. He works as a long-distance truck driver and does not regularly exercise. The patient reports primarily eating fast food for lunch and dinner. His vital signs are normal, blood pressure is slightly elevated. Physical exam reveals no conjunctival infection or pallor. His pupils are equal, round, and reactive to light. His extraocular movements are intact. The thyroid is non-palpable. He has a regular cardiac rhythm without murmurs, drops, or gallops. Lungs are clear to auscultation. Everything seems normal. There is decreased sensation over the toes and plantar aspect of the feet bilaterally. A fasting finger stick glucose level is 138. The patient is advised to make lifestyle modifications and repeat fasting labs at a later date. Which of the following best describes the pathogenesis of this patient's most likely underlying condition? Okay, I see 1D. I see 1E, both with hesitation. I see an A. B. Okay, whoever gives me an answer, give an explanation with the answer. Okay. What do you think this guy has then? What is it? Okay, someone is saying diabetes type 2 and someone is saying MODY2. Okay, so it's diabetes type 2. MODY2 is usually in younger age, like 20s. So it's mature onset of diabetes in the youth. So E. So why E? Insulin resistance. Okay. Can't be E unless it's late stage. What about the others then? Okay, like, so let's go to the answers one by one. Anti-glutamic acid decarboxylase antibody production. So anti-GAD basically. Does anyone know anti-GAD antibodies? To be honest, I searched your lectures, yes. Okay. Where is it found? It's basically not found in diabetes type 1, it's in diabetes type 2. Autoimmune destruction of pancreatic B cells. Where is this? Type 1 or type 2? Okay, type 1. Drug-induced insulin desensitization, which is he's not taking any drugs or anything, so that can't be it. Genetic defect of glucokinase gene. This is MODY2, right? Glucokinase is MODY2. So the only answer, like none of them is diabetes type 2. The only answer can be that yes, relative insulin deficiency, because maybe, as you said in the beginning, diabetes type 1, there's going to be elevated insulin. However, later there's going to be decreased insulin. So just by process of elimination, none of A, B, C, or D could be the answer. So the only answer is going to be E, which is relative insulin deficiency. So in type 1, yes, A is found in type 1. So anti-islet cells, anti-beta cell, anti-islet antibodies, anti-beta antibodies. MODY usually presents like 20s, something like that, like younger age. It's of the youth. 45 is usual presentation for diabetes type 2. So yeah, in type 1 diabetes, it's completely insulin dependent. There is, as we said, autoimmune destruction. However, note that although there is antibodies in type 1 diabetes, the destruction of the pancreas is not through antibodies. It's due to either like Th1 mediated. So this secretes cytokines like interferons, which kill the beta cells, or CD8 positive or cytotoxic killer cells, which are going to kill it directly through granzymes and perforins. Can anyone tell me like what a trigger for type 1 diabetes can be? Like why would suddenly there be an autoimmune? Okay, yeah, infection, mumps. So basically because of the immune reaction against the virus can also cause an immune reaction against the antigens of the beta cells, and that can cause destruction. But remember, it's not through antibodies. So that's for type 1. And there's completely no insulin. In type 2 diabetes, it starts usually as insulin resistance. So it's insulin independent basically. In the beginning, like you said, there's going to be high insulin because it's not working. However, after a while, there's going to be beta cell destruction. And due to the beta cell destruction, there's going to be decrease of insulin. But it's not going to be completely disappeared like in type 1. That's why it's relative insulin deficiency in the answer. Usually it can be the hypothesis is that it's due to reduced tyrosine phosphorylation and increased serine phosphorylation of the insulin receptor. Decreased tyrosine and increased serine. Okay. This is the next question. Which molecule out of these can increase insulin sensitivity? Okay. Leptin. Okay. Okay. What's the other molecule? You're correct. It is leptin. What's the other molecule? Adiponectin. And what regulates them? Like, what's the gene? Yeah. Okay. Perfect. And some medications do act on this one. So I think they specify it, the pioglitazone, the glitazones. Okay, wait, this is a pharma question. Where are pioglitazones contraindicated? Heart failure. Why? Okay, yeah, because they cause fluid overload. Perfect. So basically leptin and adiponectin, they're going to increase insulin sensitivity, opposite of all the others. These two cause insulin resistance. This one causes increased inflammation and therefore increased serine phosphorylation. Basically, all of them are going to increase the resistance except leptin and adiponectin. Okay. So as you can see here, just a quick histo. There's going to be like the T cells. In peri, the T cells are peri adjacent to the islet. In intra, they entered the islet, but they didn't completely destroy it. Here you can see that the T cells are all around. This is when you're going to get type 1 diabetes presentation because you need to have more than 90% of the islet destructed for the symptoms to appear. Okay. Okay. Next question. A newborn was found to have insulinemic diabetes. What is the most likely? Okay, wow. Okay. So 2 C's, 1 D, another C. Okay. Yes. Yes. Perfect. Okay, so it is C. Where's glucokinase mutation? MODY2. What about CTLA4? Type 1. Okay. TCF7L2. Type 2. And PTPN22. Type 1 again, yes. And these, they share it with Hashimoto's thyroiditis. That's why I always found it that sometimes diabetes can come with Hashimoto's, like they're similar, kind of the same antibodies. So yeah, diabetes type 1 usually has an association with the HLA, DR3, and DR4, and the rest, you know. So the extra one here, the neonatal, can either be this gene or ABCC8. So yeah, I think now it's Momo's questions. Do you
Okay.
guys understand everything?
Oh yeah.
Sorry. Do you guys have any questions from the previous? Okay, I'll hand on the mic to you.
Okay. A 28-year-old, otherwise healthy man has had headaches for the past 2 weeks. Physical examination yields no findings except for high blood pressure of 174. And abdominal CT shows an enlarged right adrenal gland. So we're moving on to adrenal glands. A right adrenalectomy is done, and this figure is shown. Which of the following laboratory findings in his blood was most likely reported in this patient before surgery? Okay, 2 people said F. Does anyone have A and F? Okay, nice. What's the I guess, what do you think of the tumor? Like, there's this, like, I know the adrenal gland has many layers, right? Which one do you think is affected? Okay, good. So Conn syndrome will have an increase in which hormone? Good, yes, aldosterone. Aldosterone, yeah, good job. And So why did you say aldosterone? Like, why not Cushing, for example? What's the finding in this case that, yeah, high blood pressure. Good job. So whenever you see high blood pressure and so, yeah, high blood pressure, or for example, like potassium levels are affected, you would know that aldosterone is the hormone that's being like maybe overproduced, right, with hypertension. So it's absorbing so many okay, so it's absorbing so many like water and sodium. So it's like the blood pressure will rise in your body. Why can't it be a pheochromocytoma? Yeah, it can. So yeah. That's honestly, it's fair. So pheochromocytoma usually presents with, yeah, you're right. For the gross picture, you're right. Yeah. Wait, Shaimaa, wait, what were you saying? Sorry.
No, I was just gonna say that pheochromocytoma is gonna be in the medulla, and
Yeah.
also you
Also, yeah. Go ahead.
presentation. You said you can continue.
Yeah,
But
it's okay. So no, you're right. Thank you. So yeah, pheochromocytoma. I know the growth is like he said that it's large and yellow. Yeah, but it should be in the medulla, and usually they won't like give, for example, they might say hypertension, but they'll say episodic, or like episodic palpitation. Like these are the symptoms usually. Yeah, maybe they might like give you a clear case. But again, here they said it's like persistent headache for 2 weeks, high blood pressure. Yeah. Fio also has new onset diabetes. Good. So the answer, because so yeah, so A and F. So now that you excluded Fio because it's now you're talking about the cortex tumors, uh, do you all agree with F, low renin levels? Okay. And yeah, good. So we have low renin, high aldosterone, right? Because of renin is the one that secretes RAAS. Okay, is everything clear? Okay, yeah. Okay, good. Um, Wait, can you go to the next question? Sorry. Okay. Okay, so this question, a 55-year-old man has experienced increasing lethargy for the past 7 months. Physical examination shows hyperpigmentation of the skin. Vital signs include temperature, pulse. These are all normal, I believe. Blood pressure is a bit low. Laboratory studies include a cortisol level of 3 at 8 a.m. with a serum corticotropin level of 65. Which of the following diseases most often occurs in patients with this disorder? I'm sorry I put the cortisol level without like the normal value, but yeah. So two people said C. What do you think like this so even without the labs, by the way, you can look from the presentation, right? Polyglandular syndrome. Okay, good. So wait, do you mean by APS the autoimmune? What do you mean by APS? Oh, okay, polyglot. Okay, good. There's another like word for it. So, like, what's happening to the adrenal gland mainly? Or okay, wait. Let's talk about presentation. What do you see on physical exam? From this case, at least. Adrenal. Okay, adrenalitis. Yeah. So, do you see? Okay, for example, wait, so okay, two people said C. Does anyone, can someone explain like why did you choose, for example, thyroiditis when it's an adrenal question? Like I just want to know the explanation. Low cortisol, low BP, okay. Good, yeah. So the adrenal gland is being affected and you have decrease in cortisol. Yeah, good job. So they are associated. So usually, okay, so whenever you see this presentation and you have low cortisol, hyperpigmentation, low like blood blood pressure and so on, Hyperpigmentation is an indication of what? Like which hormone is increased that gives hyperpigmentation? This will come in a late. Good, ACTH, yeah. So that means something is affecting the adrenal gland so that the ACTH in your pituitary is trying to tell your body to secrete more, right, of the hormones. So that means the problem is in the adrenals. So you have low cortisol, you could have low aldosterone. So all of this destruction of adrenal gland is associated with a lot of other autoimmune diseases such as Hashimoto thyroiditis. So good, whoever said C is correct. Yeah. Is it clear for everyone though? Okay. Yeah, good job. Yeah. The most common one is actually with thyroiditis and so on. So good. And diabetes would probably be type 1 more, not type 2. Okay. That's why. Good. This is a picture like differentiating between the two just because it's coming, like it might come up. So Addison's disease will have kind of the same presentation as in the last case. They'll have hyperpigmentation because of the ACTH, hypoglycemia, hypotension, so on, weight loss. Cushing is the complete opposite. They'll have high cortisol level, like only the cortisol level is affected, and they'll have weight gain, moon phase, like rashes and stria. Okay, so as long as you know the difference, you can differentiate between the two, then like you're good with this topic, inshallah. Okay, this is an easy question, but an XX infant is found to have external male genitalia and internal female genitalia. Examination reveals decreased blood pressure while sodium level is 132. It's a bit low. Bilateral adrenal cortical hyperplasia is present. Deficiency in which of the enzymes? Yeah, this is easy, but it keeps coming. Like it's recurring a lot of times. So yeah, 21 hydroxylase. We even got in fourth year this question, so okay.
Comes a lot. But there's like a slight trick that is
Yeah, go ahead.
yeah. If it starts with one, then it has hypertension. If
Mm,
it ends with one, then it's going to have female virilization. So this one does not start with one, so there's hypotension instead, but ends with one, so there's female virilization.
yeah, and someone said hypertension is B, you're right. 11 hydroxylase is hypertension. Okay, good. I just wanted to make sure like you guys knew this one. I think clear. Okay. Another one, a 27-year-old man has headaches that have occurred frequently for the past 3 months. He is afebrile and his blood pressure is 100, it's high. There are no neurologic abnormalities and no visual defects. However, he has an enlarged thyroid. Laboratory shows serum calcitonin level is elevated. Total thyroidectomy is performed and it shows multiple tumor nodules in both lobes. They are composed of neoplastic cells separated by amyloid-rich stroma. Which of the following morphological changes in adrenal gland is most likely to be present in this patient? Okay, A. Someone said it. Okay, so this is why I wanted to like relate to the first question. So the previous question we had before said kind of the same, right? Amyloid, and you guys knew that good. So this thyroid is like, which cancer is it again? The thyroid carcinoma, which type? Medullary, yeah, good. And someone mentioned the syndrome that I was looking for. So, men, yeah. So this is where kind of pheochromocytoma comes into play. And I know this one headache, it's the same like hypertension headache, so it will be more clear, inshallah, don't worry. Headaches, again, they said frequently, like it could be like on and off, which is the similar presentation. But from the overall question, again, you have medullary thyroid carcinoma, and that's why it points to pheochromocytoma. Okay, so wait, what's the answer? Can someone tell me again which letter do you guys think? Okay, good. Yeah. So A is the answer. Is there any confusion with any of the other choices, or is it clear? Hopefully it's clear. So this is a very nice, like I use this to memorize men 1 and men 2. So men 1 is all three P's: pituitary, pancreas, parathyroid. Okay. Men 2A is two P's and one M. because now you're going into the two, like it's different from MEN1. So 2Ps and 1M. Parathyroid is the same, MTC, medullary thyroid carcinoma, and pheochromocytoma. So these can happen together in a syndrome called MEN2A. MEN2B is different. Usually we never usually got questions on this, but if you see mucosal neuromas, like that's the addition. There's also Marfan, like the person will come presenting like Marfan syndrome. So all these are M's. The only P is pheochromocytoma. Okay, so either way, pheochromocytoma and medullary thyroid carcinoma are related. So for example, someone comes with presentations of pheochromocytoma, you usually check for MTC in that person and in like family involved. And you can do a thyroidectomy, if I'm not wrong, to prevent like this recurrence, okay, in cancer. Is everything clear? Okay, good. Shaimaa, is yours the next one? Oh yeah, okay. Good.
Yep. Okay. So before I start a question, what do you guys see in this image? Koilocyte. And why do you say it's a koilocyte? What are the changes? Perinuclear halo, nuclear enlargement. Okay, irregular, yes. There is one more, which is nuclear hyperchromasia. So these four encode the koilocytic changes, which, as someone mentioned, yes, HPV. Which types of HPV can cause cancer that are high risk, basically? 16 and 18, yes. And recently also 31 and 33. Okay. Yep, 16 is more common than 18. So now we move on to our question. A 36-year-old woman is evaluated for an abnormal pap smear. A cervical biopsy shows atypical squamous cells throughout the entire thickness of the epithelium, with no evidence of epithelial maturation. The basal membrane appears intact. What is the appropriate diagnosis? D. Okay, okay. Why not A? That's really easy. So is A correct? Okay. Yes. But okay, why is it not B? Okay. Why is it not C? Okay, so D you said is correct, and E, what is this one called? No. Squamous metaplasia of the transformation zone within the cervix. Not lichen, within the cervix. Yeah, just cervical ectropion. Yeah, yeah. Okay. I just want to say that clear cell adenocarcinoma can happen in the cervix, but it's very rare. You usually have to know the squamous cell carcinoma. Okay. So you're correct. It's severe dysplasia CIN3. So as you can see here in this not very clear picture, you have this is like the normal cervix. When you have CIN1, which is the neoplasia, there is only to the like 1/3 of the cervix is affected by the koilocytic changes or metaplastic neoplastic changes. Sorry. In CIN2, it's up to 2/3. In CIN3, it's the full. And that's when you can also consider it as carcinoma in situ, when the basement membrane is still intact. The moment the basement membrane is gone basically, or is invaded, it becomes an invasive cervical carcinoma. Okay. Again, CIN1 is considered as a low squamous lesion. However, in CIN2 and CIN3 is considered high grade. So yeah, that's basically it. The next question. A 28-year-old sexually active woman comes to her physician for a routine health maintenance examination. There are no abnormal findings on physical examination. The patient has been taking oral contraceptives for the past 10 years. A pap smear shows moderate dysplasia or cervical interepithelial neoplasia type 2. What is the major significance of this finding? B. Okay. Yes. Okay. Correct. You guys are correct. What is condylomata acuminata? Yeah. So the warts, low risk. Yeah. Okay. It's not a polyp, and nothing to do with oral contraceptives. CIN1 is easy to be treated, or it can reverse. So you just leave them be. However, when it becomes CIN2 and CIN3, now the risk is much higher, and you have to like either continue screening or try to take it off, excise it, and so on. So cervical cancer, as you can see, is usually squamous cell carcinoma. However, it can be adenocarcinoma. Both adeno and squamous, they're all from HPV. And what are the findings? You can see here to tell you that this is squamous cell carcinoma. Two main findings you find in every squamous cell carcinoma that's well differentiated. Keratin pearls, and which you can't really see, but you always say. Yeah, so desmosomes are intracellular bridging. Usually cervical cancer happens in the transformation zone. Why is that? Why does it usually happen in the transformation zone? Even CIN, usually in the transformation zone. Yeah, why is it a weak area? Are you correct? Like what happened there? Yeah, the squamous cells, they're not true squamous cells, they're metaplastic. Yeah. So these are weaker, and they're usually there might be not so much like there's a little space between where the HPV virus can infect it and invade it, and therefore they're the most likely cells to be affected and get cancer. Though the cervical cancer can either be invisible, so it's just invading deep down, or it can be exophytic and it grows out. Okay, next question. A 45-year-old female was found to have cervical carcinoma that has extended to the pelvic wall. What stage of cervical cancer is she in? 3, 2, say 3. Okay, what is stage 0? I'm going by 1. Carcinoma in situ. Okay, stage 1. Invading basement membrane, but what about its position? Yes, it's confined only to the cervix. What about stage 2? Okay. Basically, yes. It didn't reach the lower third of the vagina yet. However, and it went out of the cervix. And it didn't extend to the pelvic walls either. What about stage 3? To the pelvic wall and the lower third of the vagina. What about stage 4? Yeah. Distant metastasis or adjacent organs. Yes, it can be to the uterus, ovaries, adjacent organs. Do you guys know how does cervical cancer like transmit? Is it hematogenous, like through blood or through lymphs? Yes, through lymph nodes. That's why you don't usually find what is it called? Like distant metastasis until it's very late. So you're more likely to find adjacent organ metastasis. Like it spread to the adjacent organs. Okay, so as you can see, stage 1 is only confined to the cervix. Stage 2, it's within the cervix, but it still didn't go down to the lower third of the vagina or the pelvic walls. Stage 3, it went down and is in the pelvic wall. Stage 4, خلاص, it's either adjacent organs or metastasis, distant metastasis. But mashallah, you guys already know everything, yani. I don't think you even need this review. So the next question, a 28-year-old female came to the ER after she ruptured her membranes. She reported developing a fever. The amniotic fluid was found to be cloudy with purulent exudate. A biopsy of the placenta is shown, and umbilical cord was shown to have vasculitis. What is the most likely diagnosis? Okay, first, what do you see in this image? Okay, specifically, like what are the cells inside, maybe? Lymphocytic or PMN? Which one? Yes, neutrophilic. It's not lymphocytic, which PMNs are neutrophils. So neutrophilic infiltration, there's edema and so on. So this is right. So there is chorioamnionitis. So why did you guys choose B and not C? Because the slide is B. What about C? Because C is also chorioamnionitis. Why is it appendicitis? Mhm. Both of these are ascending infections. Both of them are ascending infection. The correct answer is B. The correct answer is B. However, what in this thing tells you that it's B? Neutrophilic infiltration is found in both. Yes, umbilical cord. No, rupture can also happen in just chorioamnionitis. However, the involvement of the umbilical cord with vasculitis, this is when it's phenicitis, at least according to your slides. So yeah, so that's basically it, because the vasculitis and the involvement of the umbilical cord. Otherwise, it's chorioamnionitis. Okay. A 26-year-old woman in the 3rd trimester of her first pregnancy develops persistent headaches and swelling of her legs and face. Early during her pregnancy, a physical examination was unremarkable. However, now her blood pressure is 170 over 105, and urine analysis reveals slight proteinuria. Which of the following is the most likely diagnosis? Okay, E. Okay, okay. So, why is it not A? No seizures, yes. So eclampsia is when there's seizures. Nephrotic. Yes, there's proteinuria, but this is pregnancy and the increased blood pressure. You're more likely to think about preeclampsia. So yes, that is correct. This is something that was deemed important in your slides, which is to remember what are the placental abnormalities that you find in preeclampsia or eclampsia. So do you guys know what is the main cause of preeclampsia? Like, what's the reason? Give some time because it's a bit longer, or you can just say, yes, okay. The spiral arteries, there's resistance, and that causes decreased blood supply and so on and so on. So the important things, like the placental abnormalities, is you're going to find infarcts, hemorrhages, and premature maturation of the placental villi, and fibrinoid necrosis. So if you remember those four things, these are the abnormalities that you can find in the placenta in preeclampsia. Okay. Next question. A 25-year-old woman in her 15th week of pregnancy presents with uterine bleeding and passage of a small amount of watery fluid and tissue. She is found to have a uterus that is much larger than estimated by her gestational dates. Her uterus is found to be filled with cystic avascular grape-like structures that do not penetrate the uterine wall. No fetal parts are found. Immunostaining for P57 was negative. Which of the following is the best diagnosis? B, B, B. Okay, why not A? No fetal parts, okay. Another thing is like the grape-like structures. Yes, everything. The site of the villi. So yeah. Invasive mole is when you either have a complete or a partial, usually with complete, it starts invading the uterus wall, the endometrium. Placental site trophoblastic tumor is another thing I don't think was written in your slides. Choriocarcinoma is something that can happen after someone has hydotiform mole. For the villi. What does it say? Tumor. Yeah. Okay. So this is just a screenshot from first aid. So as you can see, this is the grape-like cystic structures. And what do you call this finding on ultrasound? Snowstorm appearance. Yes, perfect. So basically, as you can see, in complete mole, it's basically what happens is that there's two sperms that go into an empty ova. So that's usually in complete mole. However, in a partial mole, two sperms, they fertilize one ova. So you end up having 69 pairs of, what do you call it? 69 pairs of chromosomes, okay? And as we see, or we're going to see later, there's going to be in the complete mole, there's going to be edematous villi. And in partial mole, you're going to find some villi that are abnormal, but mostly it's fine. You're going to find no fetal parts in the complete mole, but there's going to be fetal parts in the partial mole. As you can see here, the P57, there's no P57. However, in partial mole, there is going to be P57. Here, the reason is because it's only expressed by the mother. In complete mole, it's two sperms. There's no ova. That's basically it, and the snowstorm appearance and so on. As you can see here, the invasive mole is more likely to happen with a complete mole rather than partial mole. Also for choriocarcinoma is more likely to happen in a complete mole than a partial mole. For choriocarcinoma, it's basically after a mole happens, you might develop it. Doesn't need to have a mole. Sometimes just like if you get pregnant, you're at increased risk for it. However, there is higher risk with having a mole. It's also going to produce beta HCG because it's chorionic. So there's going to be HCG. And one thing about it, it's going to, if it metastasizes, it goes to the lungs. So if someone comes with choriocarcinoma, you're going to do X-ray, just X-ray, and you find metastasis, you know that's it like spread. It's already like stage 1. And they call it cannonball metastasis of choriocarcinoma. Another thing that you might find specifically in choriocarcinoma are thecal lutein cysts in the ovaries. So that's basically it, kind of. Yeah, I think that's for the moles. Do you guys have any question related to this? Okay. Oh, good. Okay. I think this is Momo's.
Yeah. We're like jumping this one again, we're back to adrenal, but again it's a very like if you this yeah no, it's fine, I just want like just to let you know. So a 43-year-old woman has had absent menstrual cycles along with increasing weakness and weight gain over the past 5 months. She notes low back pain for the past week, and she has a high blood pressure, 155 over 95. She has a prominent fat pad in the posterior neck and back, facial plethora, hirsutism, and abdominal cutaneous stria are present. Laboratory findings are sodium is low and potassium is a bit like they're kind of normal, it's fine. Her serum ACTH level is low. Which of the following radiographic findings is most likely to be present in this patient? Okay, so two of you said A. Good. Okay. Okay, so which syndrome is this for adrenal gland? Good, Cushing syndrome. So that's what I wanted to like just as long as you can differentiate between Cushing, like Addison and the autoimmune like destruction and so on, you'll be good for adrenal glands, inshallah. For overall all the questions, you guys are doing so good, mashallah. So yeah. For this one, why is it okay, so good. A is the answer, but um in what case would C be the answer? Because Cushing syndrome, as you know, that Cushing syndrome can have four different like causes or production. But in this case, why would you not choose C? Yeah, ectopic. So good, good. Yeah, yeah. So you would have to do more tests to rule out, for example, high DEXA and so on. So, okay, so the four sources of Cushing, like the cortisol, which one would have suppression with high DEXA? So not related to this case, but still. So which one of the four? High and exam. Good. Yeah, that's what I wanted to that's what I was looking for. Good job. So okay, wait, let's go back to this and then I'll go to the four sources. So ACTH in this case is low, right? So that means that the cortisol itself is being released from where? From the adrenal gland, which says here adrenal solid mass with CT. You will find that. If ACTH was high, that means that ACTH being secreted is the problem. Like it's the issue causing increased cortisol. So that in that case, it would be ectopic. You would have increased ACTH with pituitary tumors, with ectopic, like in the lung, for example, and so on. Yeah, I saw just now that E also has cella turcica enlargement, which is kind of like the pituitary gland tumor. Okay, so the four sources again, just to summarize, you have pituitary adenoma that can cause increased ACTH, increased cortisol. You could have ectopic, which is like what we mentioned, the lung. It could have someone mentioned very good, small cell lung carcinoma, which can produce ACTH. The other one is exogenous, so someone taking cortisol like through glucocorticoids like drugs and so like medication. And the fourth one is adrenal glands themselves, putting too much cortisol in the blood. So ACTH would be low. So which one of these four would have suppression with high DEXA? Do you guys know? Yeah, good, pituitary gland. E, yes, yes, good job. So just to be clear, so there's low dose dexamethasone suppression, high dose. If uh it's like if it's not suppressed with low dose, it's either pituitary or ectopic. If it's suppressed with high dose, which is the next step, then it's pituitary gland. So good. Is everything clear for at least for Cushing this syndrome and disease? Okay, good, good job. Okay, so for the next one, now we'll move on. As you guys can tell, it's now we're going into the breast endocrine lecture. So a 35-year-old nulliparous woman complains that her breasts are swollen and nodular upon palpation. Mammogram discloses foci of calcification in both breasts. A breast biopsy reveals cystic duct dilation and ductal epithelial hyperplasia without atypia, which is shown. What is the appropriate diagnosis? Okay, someone said C. Well, one of you said E. Okay. It, okay, what A? Okay, wait. I like that there's a different answer. But it's good. Like I want this type of discussion so that you guys can learn for the final. Okay. So what makes so each of you who's saying like your answer, just tell me like why do you think that is? Like is it from the picture? Is it from the description, presentation? Why do you think that's the answer? And then I'll show. Okay, that's not okay. So A because calcification, no atypia, just change of cystic. Good. Wait, you said C. Okay, good. Does anyone have any other like guesses or any other answer that you guys want to say? Like, what do you think this is? Okay, so someone who said microcalcification, yeah, that's a very good point. Ductal carcinoma in situ will have microcalcifications that you can find on mammogram. However, the changes with ductal carcinoma in situ would have things like so it would not invade the basement membrane because as like from the word in situ means like above, so it's not invading yet, but it would have mitosis like changes in the epithelium itself. So that rules out ductal carcinoma because it said without atypia. I know there's ductal hyperplasia, but yeah. So and calcification can also be seen in cystic disease. So okay, so the answer is C. Good. So whoever said C, good job. And like it's okay because like from this question you learn and later on. So I found someone that said E also. That's a very good like answer. But intraductal papilloma happens like it will have another presentation which is like bloody discharge from the nipples, for example. That's one of the very like key feature. Um, and at the same time, like fibrocystic change from the name, it's cystic. Do you guys see that in the case? Cystic duct dilation and ductal hyperplasia. So anything to do with ducts, if you see cysts, like big cysts in the histology, without atypia, fibrocystic change is the answer. This actually is one of the most common uh, like pathologies in the breast, like fibrocystic. So instead of cancer, even though there's calcification and so on, it could be just normally like fibrocystic change. Okay, is that clear? Like, because I know there was A and E and C. Is it clear for everyone? Yeah, so hyperplasia can happen. So the main thing is with or without atypia. So is there just hyperplasia with like normal, I guess, without atypia, like normal cells, without changes in mitosis, nuclei, and so on. So it's like not cancerous in a way. Does that make sense? So for example, if you like, for example, this is a very simple example, but if you like scratch like your skin, so because of the friction or anything like in mucosa, there might be hyperplasia, which will cover that like injury, right? So hyperplasia by itself is not cancer, or that's why, yeah, it's a normal process in breast due to hormone. Yeah. Okay. Does that make sense? Okay, good. Yeah. But good question. Good. Okay. Oh, and fibroadenoma is another important one, but I'll explain about it later. Yeah. Okay, so next question. 54-year-old woman complains of bloody discharge from her left nipple. Oh, I said that from her left nipple. Okay. Physical examination reveals a nodule in the breast tissue, which is surgically excised, and then histologic is shown. Okay, so everything's here, and you guys said E, so good uh is the answer. But histology, the most important thing is you guys can know from the presentation and histology. So bloody discharge is like number one. The second one, cuboid and myoepithelial cell lining the vascular connective tissue, cell lined vascular connective tissue core, which project into a like a lactiferous duct or breast duct. So intraductal papilloma, do you know another cause of bloody discharge so that you guys don't get confused from this one? Yeah, cancer could, again, not all cancers, but yeah, cancer could be. What else? I remember duct ectasia has like, it's like not clear fluid, I remember. Even Paget disease, again, it's a different thing. So Paget would have something else, like it would have skin changes and so on. Papillomatosis, I think, are you talking about the cancer? Because there's another type, yeah. But generally, okay, no, just know that cancer could have bloody discharge, but the main important thing, like at least in according to your slides in third year, bloody discharge, the first thing you think of is intraductal papilloma, unless otherwise they have, like, for example, like it shows clearly that it's cancer or something, right? So here it's myoepithelial, there's no atypia, they're not saying anything like that. So it's just vascular core. The rest, lobular carcinoma, yeah, see, so carcinoma, you don't have to think about that right now because based on the picture. And Paget's disease will have something, they will mention in the case, something in the epidermis or the epidermal layer or the skin or the areola. So something that you can see, okay, along with the blood discharge. So yeah, is it clear? So I'm glad you guys got it, but I'm just trying to explain the other just. Okay, good job. Okay. 60-year-old man presents with painless bilateral enlargement of both breasts. The patient has a history of nodular prostatic hyperplasia, is taking medication for hypercholesteremia. Physical examination reveals no discrete breast masses. Yeah, so no masses or enlargement. Which of the following is the most likely cause of breast enlargement in this patient? So BBV. So what's this called? Do you guys know like the name for this condition? Yeah, gynecomastia. So gynecomastia, again, it's not cancer or anything. Wait, I'll go to the answer in a bit. So the gynecomastia is not cancer. So this person doesn't have breast masses or axillary lymph node enlargement, which rules out cancer, right? So anything that you guys see here, like for example, neoplasm, you can cross it out. Okay, so they're saying, what's the cause of this breast enlargement? Why did you say B? Like, why cirrhosis and not the rest? What's like different about cirrhosis in a way? Yeah, it's in male, yeah. From GIT, yeah. Okay, so cirrhosis is you have like fibrosis in the liver, right? Nodules. So what causes the enlargement of the breast? Like how is liver related to to from GI? I like that. I like that answer. But yeah. Or what generally like what's the hormone that's responsible? Yeah, good. So that's estrogen. So in cirrhosis, because estrogen is not being metabolized, the liver is damaged, right? So estrogen will increase in your in your blood, and this is what causes breast enlargement, even in especially in males. Like it's very more prominent in males. Okay, is that clear? So cirrhosis is right. That's the answer. Why? Because of increased estrogen, which causes proliferation of ducts, breast ducts, and so on. Good. I think this is, if you guys don't have any questions, we can move. Okay, another another last question. A 45-year-old woman discovers a solitary, freely movable mass in her right breast on self-examination, which is confirmed. Mammography demonstrates calcification. Okay, that's one. With a linear configuration in the region of the breast mass. A breast biopsy reveals large pleomorphic epithelial cells confined to ducts with central zones of necrosis. What is the appropriate pathologic diagnosis? So it has like mostly all the points that I want you to know about this certain disease. So someone said D, people said B. Okay. So why do you think? So if it's B or C, okay, comedo. Yeah, that's B. Good. Okay. Okay, what points this slide is comedo? Yeah. So central, good. So the histology itself says so many things about what? About the like the comedo type. Yeah. So even ductal cancer. Yeah, I'll get to that. Yeah. So again, breast cancer, like there's so many types. There's in situ, like invasive, there's this fibroadenoma, the freely movable mass, yeah. So some ductal carcinoma, if they're not maybe like not invasive yet, especially here, since I said it's in situ, right? So it's not invasive yet, it can be movable. I'll go to the invasive one, it's more like hard, it's firm, and it's not movable, right? Not mobile. But generally, look at the overall picture of the like presentation. So you will have epithelial cells confined to ducts that are dilated also with central zones of necrosis. So this necrosis is kind of change and pleomorphic, if you realize. These two changes kind of point you towards cancer, not so without the ducts alone, right? Fibrocystic was only the ducts being hyperplastic and so on. This one, necrosis, is a very, very big sign of cancer, as well as, again, pleomorphic epithelial cells. Did I answer your question about the freely movable mass? Usually, if it's not invasive yet, if it's early stages, it can be, yeah, it can also be mobile. So this is why we do mammograph, we do histo, so to differentiate like which one is which. For example, if like a mass was movable, let's say, and you immediately rule out cancer, it might be cancer, like who knows, right? So you have to keep cancer still in mind, especially after seeing the histology slide. So yeah, so for the answer, this one is B. Wait, can you move, like, can you like click on there? Okay, I just want to ask one more thing. So medullary carcinoma is a type, but yeah, it's more of invasive. Okay, phylloides tumor, what do you guys know about that? Like what rules out, because that's another like important topic, but what rules out phylloides in this picture or case? You can just give me one because there's a good, yeah. You would see instead of like epithelial being pleomorphic, stroma. You would see stroma, fibroblasts, all these types are phylloides. No glistening surface. Good, yeah. And do you guys know the shape? Like it's called there's a specific shape. Yeah, leaf-like. Yeah, yeah, good. So if you ever see leaf-like shape, like big shapes, that's phylloides tumor in histology at least. Good. Okay. I hope that's clear. Okay, so I just like combined pictures from your patho slides because one important thing in third year is like you have to know your pictures very well. So I just put, like I said, there's variation. So ductal carcinoma could be in situ, like on this side of the, right? So this side has a lot of types. The one with central zones of necrosis, like you guys said before, is comido. That's the type of ductal carcinoma in situ. And then below you'll see other types such as papillary, medulla, and so on. Uh, the one on the right side, it's invasive. Do you guys see? So in gross, it would be very firm and hard, like mass. Usually this is like advanced case, so that's why it's not movable. And it would have like invasion into the basement membrane, into stroma, everything. So it would be like a messy picture more, right? Than the other ones, which is confined to the ducts. All of them are confined. Now, in the next slide, I put also for lobular because there's two important things, mainly for lobular, so you guys know. Lobular carcinoma in situ is, again, do you guys see? It's within the lobes. So within the lobes, it's not invading anywhere. Plus, the important thing you need to know is loss of I wanted to ask this, but I just put it. So loss of E-cadherin, which is the junctions between the cells. If they're loose, then that's how like cancer is spreading among the lobes, okay? Now, yeah. Wait. Oh, is it? Yeah, is it the? I was going to mention that's the second important thing. So invasive lobular carcinoma is different from in situ because of the soldier, like the he said it word, yeah, wait, what do you mean? Do you mean yeah, Indian file. That's I was trying to read Indian file, or like it looks like soldiers in a line, right? So that's if you see that, that's the second important thing for invasive lobular, okay, carcinoma. And these are from your slides, so if you know them, you'll be good, inshallah. Okay, I think only a few more left. Okay. A 60-year-old woman presents with large breast mass that she first detected 3 months ago. Mammography reveals well-circumscribed mass measuring 8 centimeter. Breast biopsy shows loose fibroconnective tissue, sarcomatous stroma, mitosis, and nodules and ridges lined by cuboidal epithelial cells. Which of the following is the most appropriate diagnosis? So D, okay. Good, so this is something I mentioned. One thing I wanted to say, like, why did you choose D instead of, for example, A? Because A is also, A if the picture is more benign, like no mitosis. Yeah, 60s. Oh, yeah, you're right. So these two are very important in differentiating. Another thing, do you guys see what other thing is in the case that makes it more phylloides? Although they should say, yeah, age. And then more benign, it would be more benign. It would be also well circumscribed, so that's okay. It could be either or. And size, good job. So phylloides, if you know, phylloides is larger. If you see like 8-10 centimeter, it's more likely phylloides. Again, more likely, not in all cases, but more likely you will lean more towards phylloides. And again, histology would be leaf-like, that's the difference, as well as, I was going to say one more thing. Oh, yes, so fibroadenoma, if I'm not wrong, is not as large and it's very slow growing. It's benign, like someone said before. So good job. So fibroadenoma and phylloides, if you know them, you're good. Both are stroma, both will have fibroconnective tissue. Okay. Is everything clear so far? Okay. Shaimaa, do you want to stop for like prayer break?
Yes, I think that would be
Yeah.
okay.
So I think we can start in like how many minutes? Maybe. Okay, so the next question we'll move on to, oh no. Okay, anyway, it's fine. I just want you guys to get the point. So a 65-year-old man presents with bone pain and is found to have positive Chivostek sign and increased parathyroid hormone. Surgical exploration of his neck finds all four to be enlarged. Which of the following disorders is the most likely cause of this patient? Okay, since you guys know the answer, just tell me, yeah, C due to low calcium. What else? Like, for example, so how will C cause? Good. Okay, secondary hyperpara. Good job. So good. So whatever, all of what you guys said is correct, and that's the main point that I wanted you guys to like know from like this question. So okay, so increased parathyroid hormone can happen either primary cause, things like adenoma, hyperplasia, tumor, and so on. These three are the main causes. Secondary is other things affecting the parathyroid hormone, such as chronic renal failure. So chronic renal failure is actually the most common cause of secondary hyperparathyroidism. Why does it happen? Like, do you guys know? Oh yeah, someone mentioned, sorry, low calcium. So because of the low calcium, uh, because the kidney is not able to reabsorb, that's why the parathyroid thyroid hormone is trying to like increase it. And someone pointed this out very, very nicely that all parathyroid thyroid glands are enlarged. And that's why you can rule out which answer from this one. At least one, like maybe. Yeah, carcinoma. So carcinoma, adenoma, you can rule out. Good. And hyperplasia can be four also, but yeah, this one is like overall hyperplasia. So yeah, all of the yeah, yeah, B. Good, good. I know what you meant. Yeah, good job. So good, yeah. This is it. So secondary hyperparathyroidism. So in this case, calcium would be low, parathyroid hormone would be high. Yeah. Okay, so this one again, a 40-year-old man experiences weakness and easy fatigability of 2 months duration. Physical exam shows no remarkable findings, but calcium is 11, which is high. Anything above 10 is high, and phosphorus is 2.1, which is a bit low. Serum parathyroid hormone of 58, which is near the top of their reference range. Bone scan fails to show any areas of increased uptake. What is the most likely cause of these findings? So, okay, so is parathyroid hormone high or like low? Is it with going with calcium? Is it not? So that way you would know. Okay, someone said D. Okay, why D? Like why not the others? Because they're all causes of increased parathyroid hormone, right? You can write a short answer, it's fine. As long as you get the concept. Primary PTH. Yes. So if parathyroid hormone goes with the calcium, that means that there's nothing wrong with the kidneys. There's no secondary. It's like the primary parathyroid, like the parathyroid hormone itself is being high. So that could be a cause from the parathyroid gland, right? So E low PTH, E Yeah, so you're saying would have low PTH. Since PTH high, calcium is high. Good. So since PTH high and calcium is high, yeah, since uptake is low. Good. Yeah. So exactly. That's a very good point. So now we can rule out secondary causes such as, so chronic renal failure is secondary cause of hyperpara. What's hypervitaminosis D? Have you guys heard of that? Like, will that cause, for example, so from the name, what's in increase in what? Yeah, excess vitamin D. Good. So that will cause changes in the parathyroid hormone, but because lots of vitamin D would increase like calcium absorption and so on, parathyroid hormone would be low. So that's again like difference in levels. Okay, so the main point from this question is the three last options. So parathyroid adenoma, carcinoma, hyperplasia, right? Which one is the most common cause of primary hyperpara from these three? Yeah, adenoma. So that's why. Good job. So adenoma is the most common cause. That's one of the reasons we chose this. And from the scenario, you can see that it's primary parathyroidism. What else? Yeah, it should be D. Don't worry. In the notes I wrote D. So, oh, one more thing. In the last slide, again, there was this word that I couldn't pronounce, but it's called sign. Like, can any of you tell me what that is? Because it's an important physical finding. So, yeah, good. Okay, face. It's the one on the face. Yeah, it's the one. So just remember from CH, so cheek. Okay, the one on the cheek. So the facial spasm on your cheek. The other one is oh yeah, I'll get to that. The other one is with the T is for the arm. So it will like you'll have like flinching of the arm. Triceps, yeah. T and T. Is it low uptake in scan indicate? Wait, can you go to the next question? Sorry. The second one, yeah. This one is showing a bone scan, yeah. So the uptake that I was talking about was more of, you would see that in the parathyroid, like you would see in adenoma and hyperplasia, you would see like increased in the uptake. Bone scan, again, it's fine not to show like increased areas of uptake. This is like not related to the gland, like it's for the bone related to, like, for example, calcium. So that means that calcium is increased in the blood. Like it's a lot more, like it's not being, I guess, uh, uptake, like it's not due to reduced uptake in the bone. Do you get my point? Like it's not a bone issue. Okay? Okay. Is that clear with everyone? As long as you know adenoma is the most common cause, yeah, that's good. Okay. Okay. Wait, is this mine? I think it is, right?
I think it is, yeah.
Okay. So a 36-year-old woman presents with infertility. She complains of having had dull pelvic pain for 9 months during menstruation, which is worse than during menstruation. Physical examination and the endocrine, okay, are normal. They reveal small hemorrhagic lesions over the surface of both ovaries and fallopian tubes and abundant pelvic scarring. Which of the following is the most diagnosis? Okay, so you guys said C. What specifically is, like, why is this C? And for example, not D, for example, pelvic inflammatory disease, which is also a common cause of pelvic pain. Yeah. So yeah, I get what you mean. So increased pain during menstruation, hemorrhagic lesions, all of this points to endometriosis. Do you guys know the definition of endometriosis? Like, what is it exactly? Because there's this and there's adenomyosis, which is similar. So ectopic good, yes, good job. It's having endometrial gland stroma outside the uterus. Good job. Yeah, that's it. One more thing. Okay. Ectopic pregnancy is also it will cause like scarring of the tubes, it will have pain. But one thing that's different is the um like pain worsening with menstruation, because as you guys know, in menstruation, the wall of the endometrium breaks down. which is what causes the pain, and this happening somewhere else outside the uterus will also cause pain, okay? And over a long period of time. So yeah, ectopic is like more acute. So yeah. Is everything clear why it's not the other choices? And we can move on. Okay, good. We have a few questions left, so good. You guys are doing so good, mashallah. Okay, okay. So 45, now we're moving on to like endometrium. A 45-year-old obese woman with a history of diabetes, poorly controlled hypertension, complains of increased menstrual blood flow of 3 months in duration. Endometrial biopsy is shown here in this picture. Which of the following most likely accounts for this pathogenesis of endometrial hyperplasia in this patient? Okay, someone said A. A, good. Okay, what are the risk factors this woman has, just looking from the case of endometrial like hyperplasia? Obesity, good. Obesity is one of them, yeah. Yeah, it could be cancer. We don't know if it could be with or without atypia, diabetes, PCOS. Yeah. Lead, yeah. PCOS. Here also she has like mainly the most important thing that I want you guys to know is the obesity is a main factor. So whenever you see BMI that's high, that's above 30, you start thinking, okay, this might be cancer. Right? And also the age. So the older the woman, if it's especially after post-menopause and they have bleeding, then you would think that this might be cancer in the endometrium. So what other risk factors do you guys know of increased estrogen stimulation? Like these fall under risk factors of endometrial cancer. Do you guys know that? Because of the increased estrogen. Someone said PCOS, which is good. And yeah, good. Anovulation cycle. Yes. What else? Nulliparity. Good. So things like that, whenever you see that, you would think of that. Early menarche, late menopause. Good. Okay. So yes, the answer is A. Granulosa theca. Yeah, that's a very good answer. Granulosa is one of the ovarian tumors that will cause increase in endometrial cancer. Okay. I think that's okay, right? Again, oh, wait, sorry. We're almost done. This one, the history of oral contraceptive use. What do you guys know about that? Like, why did you choose A, not D from this case? Okay, so oral contraceptive, yeah, they didn't mention it. That's the easiest answer. Just know that oral contraceptive could be combined. You don't know, like they might be taking estrogen and so on. But the main, again, the bottom line is, yeah, excess estrogen. And also combined one contains progesterone. Combined decreases. Good. So that's the reason. This is pharma, but yeah, good job. So at least you guys know that. So that's why we give combined. Okay, you can go to the next one. Okay, so a study of patients with postmenopausal uterine bleeding reveals that some of them have malignant neoplasm that arise from hyperplastic lesions. This is not important. So these are risk factors between ages 55, 65. Okay, people are seeing B. Yeah, okay. Yeah, so the most important thing that I want you guys to know, molecular analysis of PTEN tumor suppressor gene is among them. This leads to which type of cancer or which of the choices? And since everyone said B, I'll go, yeah, I can show the answer. So this is like recall question. All of the case, the scenario is talking about a study. It's not important. The important thing is you see what's the gene affected. So P10 is another gene that was also mentioned in the other cancers, but it's also in endometrium. Okay, so that's it. Mainly that's it. You guys don't need to know about the rest. And clear cell carcinoma, we said it's in the, not the endometrium. Yeah, okay, that's fine. Okay. A 52-year-old woman has noted increased size of a red pruritic lesion on her left labium over the past 7 months. It's rough and scaly lesion of this size. Perineum appears normal. There is no lymphadenopathy, no like rectal lesions. Pap smear shows no abnormal findings. Lesion is excised and it shows atypical cells lying singly or in small clusters within the epidermis. These cells have stains with the periodic acid shift stain, PAS. What's the most likely diagnosis? Okay, BBB. Okay, okay, what's extra mammary paget disease? Like, what do you guys know, or what points you towards extra mammary paget disease? Vulvar, yeah, PAS positive, vulvar cancer, malignant of the vulva. Good. What word, I guess, in the histology points you that it's exactly like the Paget disease in mammary glands, but that's why this name in, at least here, it's called extra mammary, like outside, right? Okay, good. So I'm glad that at least everyone got it right. So B is the answer. Uh, PAS, what's the other disease that's important to differentiate from this? Small, yeah, epidermis. Good job. Melanoma. So how can you differentiate this and melanoma? What's the markers? Yeah, good. Immunohistochemistry. Good, good. That's the Dr. Abrar loves those kind of like details. So yeah. So as long as you guys know that, if you can tell extra memory, yeah. Okay, vulvar intraepithelial. Okay, that's a very good question. Vulvar intraepithelial neoplasia, can anyone say, like anyone else say what it's most associated with and why is it not in this case? That's good, yeah, HPV. So here, is there any signs of HPV? How can you tell? Yeah, so here we said pap smear shows no abnormal. So if they had HPV, it would say like pap smear shows abnormal results. Okay, is that all good? Yeah, like Shaimaa said in hers. Good. Okay, good job. Yeah. Okay, I think so these are all the same related topics. 40-year-old woman has noted pruritic patches on her vulva for the past 4 months. On physical examination, there are multiple white scaly plaques on the vulva. Biopsy of one is taken, and it shows thickening with hyperkeratosis, intense dermal inflammation. Mitosis are seen, but they exhibit no atypia. Remember, no atypia. What is the most likely diagnosis? People are saying D. Good. Okay, so for whoever thinks it's D, yeah. What's the other name for this? Do you guys know? Like, what is it also called? Yeah, good job. So from the name, you can tell squamous cell hyperplasia is kind of going with the histology. See, epidermal thickening with hyperkeratosis on top, and then you have mitosis in the keratinocytes, but without like atypia or without abnormal changes in nuclei and so on. Okay. Okay, is this clear? Shema also mentioned, that's why I'm not going over it too much. Condyloma is with warts. They're more of like warts. Psoriasis, again, not really. It's like skin, you would see more of like skin changes and so on. Okay, is everything clear? So if you see thickening of keratin, of epidermis, that's squamous cell hyperplasia. Okay, good. We can go to the next one if no one has any questions. Oh, wait. Oh, yeah, this is the next one. A 57-year-old woman recently noticed a pale area of discoloration on the labia. Pelvic examination shows a flat white area on the right labia majora. So far it looks like this, okay, and like the other one. But the main important thing is that you guys see human papillomavirus type 16 in the epithelial cells. What is the most likely diagnosis? Good, yeah. Because of the HPV, remember someone asked me before, it's vulvar. What's the other HPV type that would like be more of, it would be kind of the same answer, cancers, 18, good. Yeah, why not? Oh my God, mashallah, yeah, that's really good. We only memorized 16 and 18. But if you guys know, yeah, that's also good, yeah. What about okay, condyloma also occurs with HPV, but why is it not the case this time? Like, good, yes, 6 and 11. There you go. So good job. All of these, like, all of these were mentioned before the choices, so good. Okay, I think this is okay. I'm covering like each disease. So an 18-year-old sexually active woman has had dyspareunia followed by vaginal bleeding for the past month. It shows a red, friable, nodular mass in the anterior wall in the upper third of the vagina. This is the picture that's shown from the biopsy. Which of the following conditions? Someone even mentioned it before in the chat. Good, yeah. So the diagnosis, so the diagnosis is vaginal adenosis or clear cell carcinoma, which is due to which one? Vaginal, why not? Which is due to DES exposure, okay? This is like a very clear, wait, why not, which one? Sorry. They're aren't they the same, if I'm not wrong, they're the same, cell. Sorry, it's not cell. They're the same name, like two names for the same disease. So I remember Dr. Abrar kept saying like vaginal adenosis is the clear cell carcinoma, like it's in brackets. Exactly like how you would call the lichen planet, like that one, the simplex cronus, is the same as squamous cell hyperplasia, right? Yeah. So yeah, I mean the same thing. The main thing in the histology, do you see the cells that are clear, that have like clear cytoplasm all over? This is like what helped me differentiate clear cell from other types of, for example, coilocytes maybe, and so on. Okay, is it clear though that they're the same name? Don't worry, it's on your slide. It's probably like written in brackets or something. Okay, I hope that's clear. Okay. Lastly, a 53-year-old woman whose last menstrual period was 3 years ago notes vaginal bleeding for a week. Her uterus is markedly enlarged, but there are no masses. CT imaging reveals irregular mass in the body of the uterus. They see a hemorrhagic mass showing spindle cells with atypia and numerous mitosis. There is coagulative necrosis of tumor cells. Which of the following is the most likely cell origin? So someone said D. Okay, so yeah, so what's the what's the name? So someone said B. What's the name of the disease? Leiomyoma. Very good. But with if there's atypia, mitosis in leiomyoma, which you're close, good, yeah, leiomyosarcoma. So leiomyoma is a very benign, like it's called another name for it again is fibroids. It's a very common like mass in the uterus in a lot of women. Leiomyoma is benign. If you add, for example, atypia, this like changes in cancerous changes, it would be leiomyosarcoma, which is the cancerous part. What's the difference between this and adenomyosis? Yeah, you're right. I know how you could like mix like it could be between that, this and that. Adenomyosis would be smooth muscle cells, not smooth muscle, but the endometrial gland in the uterine like muscle there. So they're endometrial tissues in, oh, that's why you chose. Okay. There's also another presentation with adenomyosis. You would have heavy menstrual bleeding and pain with bleeding. So does that make sense? If you see menorrhagia, which is heavy bleeding due to the adenomyosis, due to tender uterus, bulging uterus, all this is adenomyosis. Yeah. This one again, yeah, spindle cells, anything you see about like fibro, like stroma, any words like this with atypia mitosis, go directly to leiomyosarcoma, the cancerous part. Okay, is that all clear? Oh yeah, and necrosis also, that's a sign of cancer. Is that clear with everyone? Okay, good. Oh my God, ovarian tumor.
Yeah. This is the last
This
thing.
is the last part, yeah.
Okay. So a 45-year-old female undergoes surgery to have an ovarian mass removed. Histologic examination of the surgical specimen is shown in the image. The neoplasm most likely originated from which of the following ovarian cells slash tissues? Okay, someone is saying B. Any other answers? No other answers? Okay, let's D. Okay, so what do you see in this image the arrow is pointing towards? Samoma bodies. Samoma bodies are present in which type of ovarian tumor? Serous adenocarcinoma. So that is from which origin? Surface epithelium. Yes, correct. So the correct answer is surface epithelium, and we're going to see all the rest here. So basically, the ovarian tumors are mainly divided into three origins: surface epithelium, germ cell tumors, and sex cord tumors. So the surface epithelium is either cyst adenoma, which can be serous or mucinous, cyst adenocarcinoma, which can either be serous or mucinous, and then we have the endometrioid, the borderline, and the Brenner tumors. All of these fall under surface epithelial tissues. For the germ cell tumors, we have the teratoma, the dysgerminoma. Does anyone know what the equivalent of dysgerminoma is in males? Seminoma, yes, perfect. Yolk sac tumor or choriocarcinoma. And why is this non-gestational choriocarcinoma? Where else did we see choriocarcinoma? Yes, after the also in pregnancy. After a pregnancy, that's gestational choriocarcinoma. In the ovaries, it's non-gestational. Then the stromal tumors, we have the granulosa cell, the theca cell, fibroma, and Sertoli-Leydig cell tumors. Okay, so specifically, just so that we know for each, in serous cyst adenoma, this is the most common ovarian tumor, and it's benign. In mucinous, it's also benign. However, when you look at it, it's not just fluid. It's kind of compartmentalized, and it has some mucus and stuff like that. And importantly, in histopathology, what you're going to see is just a mucus secreting epithelium, nothing else, kind of. And it's you're going to be able to tell that it's benign. In Brenner tumor, you're going to see these like nests of epithelial tissues that are present in the ovaries, and they usually they're similar to like urothelial tissue. In serous carcinoma, you're going to find the Momo bodies, like we mentioned before, and this is the most common ovarian like malignant. The most common benign is cyst adenoma. The most common malignant is serous carcinoma. And mucinous, the malignant is rare, and it can also be like, you know, the pseudomyxoma peritoni, which usually originates in the appendix, and then it can metastasize to the ovary. I have a question though. If there's a tumor from the GI that metastasizes to the ovary, what is it called? Yeah, Kirkenberg. Perfect. Okay. Next question. A 20-year-old woman presents for a complete physical examination. During the pelvic examination, a 5-centimeter cystic mass is found in the region of the right ovary. Radiograph shows focal calcification in the mass. What is this? B, C. Any other answer? B again. Okay, so what is what is what is special about this? Like what are the findings basically? Okay, the age, yes, and the calcification. So, what could this calcification be? Teeth, exactly. So where are these usually found? In a teratoma. So the answer would be a mature teratoma. And we're again going to see the rest here. So in a mature teratoma, which can also be called dermoid cyst, that's the other name, because the tumor contains all derm layers, you can find the teeth, the hair, and everything. However, there's immature teratoma. And the special thing about immature teratoma, like if you see this sentence, which is immature neuroepithelium, know that it's immature teratoma. If you see teeth and everything else and you don't see immature neuroepithelium, then don't think about immature teratoma. This is malignant. This is benign. The immature is malignant. Dysgerminoma, which we said is the equivalent of seminoma in males, contains fried egg appearance. So if you see a fried egg appearance, know that it's dysgerminoma, and also it produces beta HCG. So increased HCG, beta HCG is a sign of dysgerminoma. Yolk sac tumor, also there's an equivalent in the males. Specifically about it, if you look at it, you're going to see the Schiller-Duval bodies, which look like glomeruli, and they have increased AFP, alpha fetoprotein. So this germinoma increased beta HCG, yolk sac tumor increased AFP, and Schiller-Duval bodies. In this germinoma, it's fried egg appearance. Okay, the next question. A 50-year-old woman presents with a 1-month history of intermittent vaginal bleeding. A pap smear is normal. Pelvic examination reveals a left adnexal mass. A uterine curettage shows complex endometrial hyperplasia without atypia. A CT scan of the abdomen reveals a 5-centimeter mass replacing the left ovary. The patient undergoes hysterectomy and bilateral salpingo-oophorectomy. Histologic examination reveals gland-like structures filled with acidophilic material. Which of the following is the appropriate pathologic diagnosis? So the answers are C, C, Y, C specifically. What cancer, like, what in this question gave you the hint that it's granulosa cell tumor? Acidophilic. And what about the acidophilic? You mean like the gland-like structure, right? Yes. What is this called? It has a name. Call X-inner bodies. And call X-inner bodies are present in the granulosa cell tumor. So that is correct, mashallah. So basically we said we can either have a fibroma, they're all from the stroma, so we can have a fibroma or a thecoma. So the fibroma can sometimes present in something called Meigs syndrome, where you're going to have a fibroma, ascites, and pleural effusion. And I think if you just remove the fibroma, then the ascites and the pleural effusion are going to disappear and they're going to be treated. Thecoma is from the thecal cells, but it's benign and can produce estrogen. Now, the most important ones are Sertoli-Leydig cells and granulosa. So Sertoli-Leydig, we don't really have these cells normally. We shouldn't have these cells. They're in the males. However, they can have a tumor in the ovaries. And since they're male cells, they're going to produce androgens, and these androgens can cause virilization. And if you look at it inside, if you look at it histologically, it's going to look like seminiferous tubules. So that's very special about it. Granulosa is the opposite. We have granulosa cells and they produce estrogen. So we're going to have, they can produce excess estrogen and cause symptoms of the excessive estrogen. And in histology, you're going to see increased Cole X-inner bodies. Okay. So yeah. Okay, so I have some pictures because I described them histologically, but I didn't show them. So what is this one? A. mucinous cystadenoma, cystadenocarcinoma, which one? Yes, so it's just simple benign mucinous cystadenoma. This is basically like the epithelium has mucin in it. Okay, like it's filled with mucin, as you can see. What about this one? Teratoma, yes, you can see the hair, you might see some teeth, so that is a teratoma. What about this one? I didn't talk about it, بصراحة. Struma ovari, why? What do you see? Yes, exactly. You can see the thyroid follicles, the colloid. So they can also present with symptoms of hyperthyroidism. So yeah, basically it's just a tumor in the ovaries that produces thyroid hormones. Okay, what about this one? This germinoma, why? What do you see? Fried egg appearance, perfect. Okay, what about this one? Yolk sac tumor, why? What is it called? Schiller-Duval bodies, perfect. The dysgerminoma, what does it produce as a tumor marker? Beta HCG and yolk sac? Alpha fetoprotein. Okay. Oops. You saw it. Anyhow, what is this called? These gland-like structure that have eosinophilic or acidophilic inside? Yes, called XNR bodies. Okay, perfect. So we're done with the questions. Now it's like pictures and images.
Yeah, I don't know if you guys want us to like go like rapid like review of them. Uh, but you can just tell me, will we do that, Shaimaa? Like, will we go over each picture? Yeah, it's fine, right?
I think so.
Yeah, if you guys are fine with it. Okay, we can do that, yeah, for the sake of recording, of course. Okay, so this will go gland by gland. This is a thyroid, and I put pictures. For my slides, the answers are in the notes. For Shaimaa's, they're in the slides, which is nicer. But yeah, for the first one, what do you guys think, just from looking at the picture? What's the diagnosis? Okay, good, Graves. So colloid bodies, like if you see the white, the palisading, this is Graves. What about number two? Good. Is there any good? Yeah, good. I'm really glad. So decurvane or subacute, both are the same thing. Like two names for the same thing. And you can see that because of which like structure in it. Just like one main thing you can see, and then yeah, giant cell. Wait, I can't like circle it, but it's the one like it has a lot of like cells there in the middle.
Let me try and find it.
Yeah, that one, yeah. Okay. What about the third one? This is a gross kind of picture of the thyroid gland, but since it was in your slides, I just thought good, yeah. Why do you say adenoma? Like what differentiates thyroid adenoma from carcinoma? Okay, thin capsule is one. Seeing the capsule is one, and necrosis, yeah. So if you don't see any evidence of the adenoma invading the capsule or going into the capsule, that's adenoma alone and focal hemorrhage. Good. So these three are for thyroid.
Okay. So
Okay.
this is for pancreas. So what do you see in number one? Diabetes type 2. Okay, yes, amyloid. And what would it stain if you actually try to stain it? With which stain and what would it be? Yes, Congo red stain, and it's gonna be the apple green birefringence. What about this picture? Diabetes type 1, what do you see? Yes, insulinitis. What is the specific T? It's T cells that infiltrated the lymphocytes. Okay. So you're correct. This is yours.
Okay. Adrenal gland. What's the first one according to your slide? If you see big, yeah, good. Big yellow like bloody, that's pheochromocytoma. It's a very big size and it's of the medulla. It won't, so you'll see like parts of the medulla. It's like it's not hard like the cortex masses, okay? Good. So whoever said, yeah, the cortex is there. Good, yeah. And what's the second one? What do you guys think that is from the adrenal gland? Okay, good, good. Yeah, what are why are you saying it's con? Like, what are the things you see specifically for con syndrome? Good job. Oh, mashallah. That's so good because I forgot this when I was doing. So yeah, spiral lactone bodies, which are so do you guys see the holes? The pink eosinophilic in the center of each, those are spiral lactone bodies. They only happen in con syndrome where aldosterone is increased. We had a question about this previously. Good. Okay, the third one, I'll give you a yeah, oh my God, good. Yeah, so this is it in the medulla or cortex? Neuroblastomas. Medulla. Good. So two things in the medulla that's important from your lecture, pheochromo and neuroblastoma. As you can see, it's very easy to differentiate. Neuroblastoma, oh, by the way, this is a picture from first aid, so it's very good. You guys knew this, not from the slides. But this one, you'll see rosette patterns, you'll see like patterns in the medulla itself. Yeah, this one. It's called Homerite rosettes. Good job. Okay, I'm so happy here. Cervix. No.
So what do you guys see in here? What is A, B, and C and D? They're kind of sorry, the mouse is okay. Normal, and then this is if I'm going to divide it into CINs, this is CIN 1, 2, and 3. Yes. So it's just basically like this is under cytology, not histology. As you can see, the more like the more advanced it is, the more dysplastic it becomes, the larger the nucleus and the less the cytoplasm. So high NC ratio. This is like the most anaplastic, like the cytoplasm is so little and the nucleus is a lot. And here it's more than this and this is more than this. This is the normal. What about here? What do you guys see? Why cervical cancer? Yes. So here you can see invasion. So that's perfect. And here you can see how it's growing out. So this is cervical cancer. Okay. Ovarian. What is this? A follicular cyst. Perfect. And this is the most common type of cyst in general. It's benign and it's fine. What about this one? The luteal cyst, corpus luteal cyst. Then you can see it's yellow. So when you see yellow, it's corpus luteal. What about this one? What is this? Yes, perfect. PCOS, polycystic ovaries. You can see multiple cysts in here. Okay, what about this? Serous adenoma. Benign or like okay, yes. So this is just benign serous cyst adenoma. You can't really see anything different, basically. It's just there's serous fluid accumulating. However, in the mucinous, if you remember, the epithelium was filled with mucus. You can really see the nuclei, it was mainly mucus. So you have to differentiate between that. What about this one? Yes. Although I can't see them, but yes, correct. Borderline, perfect. Yeah. Again, borderline, really, you can't differentiate that much from malignant, but this is borderline. What about this one? Which type of carcinoma? Yes. So this is a mucinous cyst adenocarcinoma. Oh, sorry. Cirrus will have Momo bodies. Okay. As we saw in one of our previous questions, Momo bodies, that is in serous adenocarcinoma. However, in mucin cyst adenocarcinoma, you can see, first of all, like the mucin-filled cells, and also anaplastic, and the nuclei are weird, and the mitosis and everything is just dearranged. So this is mucin cyst adenocarcinoma. The serous Momo bodies, look for Momo bodies. Okay. What about this one? What does it kind of look like? The tissue itself. Does it look like an ovarian tissue, or does it look like something other than an ovarian tissue? Exactly. It looks like endometrial glands. So this is an endometrioid tumor. What about this one? Kind of remember that it's yellow, solid. Cyst adenofibroma. Luteal cyst is one small cyst like this. This is like there's a tumor. So cyst adenofibroma. What about this one? Brenner. As we said, there's nests of epithelial tissues within the stroma, and it resembles urothelial epithelium tissue. That's right. Okay. What about this one? What do you see? Yes, sertoli is correct, but what do you see? These are all what looks like seminiferous tubules. So that is sertoli. What about this one? Okay.
Oh, here I don't think you can see the crystals. Usually, like that's a very good finding, yeah, but it's like you'll see it very visible, like pink crystals. But usually if it's zoomed in more into the cell. So yeah. So you can look out for those too.
You
For two? Wait.
teratoma.
Oh yeah, someone said yeah.
Okay. Yep. Perfect. And what's like the keyword if you see in a question to know that it's immature teratoma? Yes, immature neuroepithelium. Okay. The last one. I hate myself. Okay, so it's basically this is choriocarcinoma. So there are only like two things I want to say. So firstly, for the surface epithelial tumors, what are the genetic mutations? KRAS and P53. KRAS/BRAF and P53. So if what is it called? So basically, you know, BRCA1 and BRCA2 are also associated with ovarian tumors. So the BRCA tumors, they're associated with a KRAS mutation or a P53 mutation. P53. So does that make them high grade or low grade? High grade, perfect. So KRAS, BRAF mutations are low grade, P53 mutations are high grade. The last thing is the difference between the gestational choriocarcinoma and non-gestational choriocarcinoma. So the gestational, it's fine. It's very sensitive to chemotherapy. You give it methotrexate and there's a very good prognosis. However, the ovarian one is resistant to chemotherapy and radiotherapy. So it has very poor prognosis and early metastasis and so on. Okay. Breast.
I think there's three more like organs or slides, and then we'll be done. So for the breast, like organs, the first one is okay, good. Yeah, fat necrosis. If you see white, like spaces, clear spaces, these are fats. Usually after trauma, right? That will be the case. And this will be the picture. What about number 2, which is the down? Yeah, fibroadenoma. Okay. Oh wait, yeah. You want yeah. Number 2 is sorry, the down one. Popcorn, Cosby. Okay, so fibroadenoma, like we mentioned before, that is the correct answer. However, what's the like if you see phylloides, it would be more of like what's the difference between this and that? Yeah, so depending on the case, depending on that, and you would see for me at least like you would see it like leaf-like, so you would see like a very strange shape like a leaf and spaces above. So this one is round, like well circumscribed, more benign. It looks more benign at least. And this is fibroadenoma and fibrous growth. Yes, good job. Okay, what about number 3, which is like the top right here? Someone said it before, but it's fine. And we had a question about this too. Yeah, lobular carcinoma, is it in situ or invasive? Good, someone said it. So invasive. Why? Because of the Indian file cells in a line, right? Okay, what about number 4? Might be a bit okay. Why Paget? Like what's the difference? Or what mainly is the difference? Like the keyword, remember for Paget? So yeah, PAS positive and epidermis. Where? So PAS positive in the epidermis. Good. And this one is in the breast, so it's not extramammary. It's the Paget disease of the breast. Good job. Okay, I think that's for this slide. It's all good. So endometrium. The first one is actually like the picture of both of them, so top and bottom. So this is a diagnosis of what? Good, endometriosis. So you have glands somewhere this one there I'm not sure which structure exactly, but it's somewhere outside of the endometrium, as you can see. What's the second, like the down picture, what is it called if you see it? Chocolate cyst, yeah. What is it? Okay, good, yeah. It's in GI, yeah, you're right, sorry. uh Chocolate cyst is what you see with your eyes. What about like what's the name for it? Do you guys know it in like diagnosis, like in that term, I guess? Or maybe they didn't, Dr. Abrar didn't say this. But do you guys, okay, it's from the name itself, endometriosis. This one, the one in the ovary is called endometrioma. Okay. If you guys haven't heard of this, then maybe he didn't mention it in yours. But if you know chocolate cyst, that's enough for that you can say that this is endometriosis. Okay. Second one, it's a very not like clear picture, but it's from the slide, so it's good if you know it. Can anyone like tell me what do you think this is? From the endometrium, okay? Yeah, it's even myself, it was hard for me. Um, Not adenomyosis. Adenomyosis is in the picture, but not number 2. But it's a protruding. So the case would be something like protruding mass in the endometrium. So what would that be? Like it would have different kind, like inside. There's no specific you would see. Good, yeah, this is an endometrial polyp. It's the last picture in your slide. So what is the finding into? Yeah, so mainly, again, it's my bad, but mainly they should say from the case, you have a protruding, they will give you a picture of the uterus maybe and a protrusion, that's a polyp. Histologically, it can be anything. It could be have glands of the endometrium, but just see like it's a protrusion, okay? From it's not the normal gland like shape, okay, of the uterus. Is that clear? Okay. So number 3 is big, so that's a uterus growth picture, and then inside it you'll see um something. Good, yeah, this is adenomyosis. I didn't bring a question on it, but Adenomyosis, you'll see what? A large, like uterus, tender, boggy uterus. What's the histology? Like, what do you see? What do you see in the histology that says adenomyosis? From the definition itself, it's fine. What is the white part? Yeah, exactly. That's what I wanted to know. Yeah. So someone said it's glands. So whenever you see spaces, lumen, anything like that, it's mostly glands, but the location of the glands is important. So do you guys see, like, even in the first picture, endometrium, you see the white these are glands, these are lumen of the glands. In the third one, however, it's not in a glandular like environment, it's as someone mentioned in the myometrium. So surrounding that white space structure is smooth muscles of the muscle cell of the myometrium in the uterus. Yeah, spindle cells. Good. Is everything clear? So good. You guys got like all of them correct. So yeah. Last slide for okay. So this is for the vagina. Number one, what do you guys see from the changes? At least, yeah, good. Lichen sclerosis, which I got a question about. Good. So you see on the top there's hyperkeratosis, like so many keratin lines. That one. And if you zoom in, obviously you will see the squamous hyperplasia, which is like this has to be zoomed in, so don't worry. Number two, it also should be zoomed in, but complex. Okay, maybe I should have zoomed in. But uh okay, so the white is not squamous. Do you see that? The white in the epidermis? Yeah. So halo, good, good. Whoever said halo is correct. So what is that? I guess what disease is it where you see halo in the epidermis? So it's different from squamous or lichens like simplex because you would see squamous hyperplasia. So not good. So whoever said VIN is correct. Yes, this is what you would see. So in for people with infected with HPV having coilocytosis, you could have VIN, like neoplasia, which is limited to the epidermis. And the main thing again, I would zoom in this picture, and you could tell from the scenario. So yeah, these are the coilocyte, like the halo cells, okay, of HPV. Condyloma is a bit different. Condyloma would be, yeah, condyloma would also have the halo like cells, coilocytes, but again, this one looks more of like it's affecting the entire length of the epidermis, so it looks more like neoplasia to me. Okay, is that clear? And condyloma on the outside, it would look like warts. It would be more solid, like solid structure. And so, is that okay? VIN is like neoplasia of the cells. Okay. What's number three? It's not it wasn't a question, but yeah, good. Papillary hydra-adenoma. So if you see that, just know, like from the like the picture, it's inside the vagina. It's condyloma. Is it actually condyloma? I remember I took it from. Oh, sorry, my bad, my bad. I'm so sorry. Yeah, I got confused with the VIN with this, but it's condyloma. But again, you would see it from the scenario case, everything, and a zoom in of the coilocytes. But my bad, yeah, it's condyloma. Even in the notes, I remember I wrote condyloma. I don't know why I said VIN. It's like, yeah, okay. What about number four? Thank you for correcting me. Thank you. What about number four? It's all these pictures should be zoomed in, but circle. Yeah, good. Rhabdosarcoma, or like you would see, like it would look like a grape-like structure in gross, but then in in like inside you would see like the rat, the tennis ball, and the bat and the tennis ball kind of appearance. So rhabdosarcoma, yes. Okay. Is everything clear? Just to make it clear, number two is condyloma. So I'm sorry for saying that. Yeah, that's it. I think that's it all from us. Thank you so much. If there's anything that's unclear, just let us know anytime. Like we don't mind at all. And I hope that this was like helpful, and this will help in your final, inshallah. You guys did very well, I can tell. And
they
yeah,
do almost everything بصراحة من الله.
yeah, mashallah.
So thank you guys for attending, and inshallah it's helpful. And if you guys have any questions, these are contacts and you can ask.
It's because